Next, I'd like to introduce the first of our keynote speakers, Dr. Dan Blazer. He joins us today after delivering a wonderful Dean's Lecture at Meharry yesterday entitled Substance Use Disorder and Light Life. Dr. Dan Blazer is the J.P. Gibbons Professor of Psychiatry Emeritus at the Duke University Medical Center. He is a native Nashvilleian and went to high school, went to high school and did his undergraduate work at Vanderbilt, going on to pursue his MD degree at University of Tennessee. He subsequently moved to North Carolina and received both his MPH and PhD degrees from University of North Carolina at Chapel Hill. Dr. Blazer, in addition to his role as the Professor Emeritus at Duke University Medical Center, he's Professor in Community Family Medicine at Duke and also serves as Assistant Professor of the Department of Epidemiology at UNC. And if you know anything about the rivalry, I'm not sure how he pulls that off, but I guess he has T-shirts he switches into as he's driving down the highway from Durham to Durham to Chapel Hill. He's well-known. He's probably the leading authority, if not the first authority, in depression in the elderly, and now has spent the bulk of his career looking at mental health disorders in older adults. He has received numerous awards and published over 450 peer-reviewed articles and 35 books. He is an expert and been a friend to me and many of the geriatric community, particularly those who worked in mental health. And so I'd like us to give a warm Nashville welcome to one of its native sons, Dr. Dan Blazer.
What I want to do today is to go through and talk with you about 4 disorders let's see if we can move the slides forward and get you. This will be sort of a potpourri. And so I'm going to look at this as a psychiatrist looks at it. I know most of you are not psychiatrists. I'm very well aware of that. But I think sometimes it's useful for you to see problems that older individuals face through other eyes. And so I'm going to hopefully help you see through the eyes of a psychiatrist 4 of the more common problems that older individuals tend to face. My good friend Peter Rabins is going to be talking about Alzheimer's disease, which is clearly a major issue. I'm obviously going to avoid that as we go through. So the 4 disorders I want to look at are mood disorders, and I'm going to concentrate on major depression, which is the more serious kind of depression. Depression has a range, but I want to focus on the more serious type of depression. The second is anxiety disorders. Generalized anxiety is the disorder I want to focus on specifically. The third is substance use disorders, and I want to focus specifically on alcohol use and abuse. And the fourth is delirium. And I call this the mother of all comorbidities. All of these disorders can overlap, but I specifically will be talking about comorbidity when I talk about delirium. So we'll keep that in mind as we go along. First is major depression. And the first issue is how well can we identify major depression in older persons? There is a sense that it's much more difficult to evaluate depression in the elderly than it is at other stages of the life cycle. So the key symptom that one looks for in depression is not depression in late life. It's not people saying, I feel so depressed. Rather, it's a symptom that says, I just don't feel anything. I don't care about anything. We actually have a name for this called anhedonia. That's not important to remember. But this sense of, I don't care about anything, I love the grandchildren, but when they come over, I don't care, that should be a clue that you are looking at depression. And there are a number of other symptoms that go along as well that are in our diagnostic criteria, but they can vary in late life. So one is weight loss or weight gain. Younger adults often will gain weight in the middle of depression. Older adults rarely, if ever, gain weight. They will lose weight. It's not a lot of weight. So somebody that's been 165 pounds for the last 20 years that drops her weight to 160 pounds, you worry about that. That potentially could be a symptom of depression. So just a weight loss that's not planned can be an important symptom of depression. Second is insomnia or hypersomnia. In other words, not being able to sleep well enough or sleeping too much. Younger people, if they're depressed, often will sleep 12, 15 hours. That virtually never happens in older individuals. Older individuals who are depressed have trouble with their sleep, insomnia. They often will be able to go to sleep okay. Well, that's not always the case, but they'll wake up frequently during the night, and then they will wake up earlier in the morning. And that can be a particular problem because if they are tired, they may go to bed at 9 o'clock, and they may sleep 5 hours, and they're up at 2. And then up at 2 o'clock, that can really present some problems for them. Another is fatigue, loss of energy. And older individuals who are depressed often will complain of having problems with fatigue or loss of energy. They can also be agitated or experience retardation. And you can see both of those with older people. Agitation is just, I can't sit still. I've just got to get up and be moving around. Retardation, that's the individual sitting in his or her bed or sitting in a chair and just sitting like this all day. Difficulties concentrating. Now, older people may have trouble concentrating for many different reasons, but they often will have concentrating problems based on their depression. And then perhaps recurrent thoughts of death or suicide. And this is something we often have to be very careful about screening. Does the older person, in fact, have problems with death or suicide? I'll tell you what I think I'm going to do, if you don't mind. I'm going to kind of look back this way because I'm having trouble reading that over there. Okay, just excuse me as we go through here. Most important thing is that late life depression is something you get by history. We have no laboratory test to do it. We have no imaging processes by which we can make the diagnosis. You talk to people. That's the way we found out how an individual gets depression. There are screening scales that can be used. I'm not going to go through these in any detail. The geriatric depression scale, the Beck scale, there are a number of scales that could be used. But primarily, you talk to people. That's how you make the depression, the diagnosis. When you are concerned about a severe depression, you certainly want to try to get laboratory data because physical illness often is interacting with depression. So you want to get blood counts, maybe a thyroid panel, some other tests also as we go along. And that's why a doctor, if he or she is a good doctor, will be following up medically when an individual is suffering from a depression. Now, these medical tests don't make the diagnosis. Occasionally they might, but they don't make the diagnosis. But they help you in terms of additional problems you have to consider in the process of treating that depression. Imaging studies have become a big thing. Maybe Dr. Ravens will be talking some about imaging studies in Alzheimer's disease or other dementing disorders. But imaging studies can maybe help us understand certain subtypes of depression, a type that we call vascular depression, but they don't really make the diagnosis, and to date, they are not particularly helpful in terms of our treatment. Now, these are suicide rates. The top line, the blue line, are suicide rates in older adults, and the lines going down are suicide rates as progressively are getting younger. These are up to about 2,000, so they're a little bit old, about 15 years old. Suicide rates tend to lag behind. The data comes to us a little later. Historically, overall suicide rates are higher in older persons, and that's driven almost exclusively by being higher in older white males. And so that's what we've been seeing. However, now we're beginning to see, for the first time in the 20th century, that suicide rates among middle-aged individuals are creeping up and maybe beginning to be equal to those that we're seeing in older persons. Since the Second World War, on average, suicide rates have gradually been going down in older persons. Now, antidepressants have been sort of the cornerstone of the biological treatment of depression. And that goes back a long time, 60, 70 years now. However, antidepressant therapy was pretty rare, relatively rare, I would say, until 1988. In 1988, a new drug came along, and that was Prozac. And Prozac was a drug that primary care doctors felt comfortable prescribing. And so during that time, we saw the increase in use of antidepressant medications increase from about 3% to about 10 to 12% in older persons. So we see the rather dramatic increase, and that actually stays up there today. Older persons, probably at least 10% of older persons in Nashville, in the United States, are taking an antidepressant. Some have suggested this might contribute to the decline that we've seen in the suicide rate. I don't think that's so much the case. I actually think that probably that decline was sort of happening anyway, but we do have a very high use of antidepressant medications. Now, these are just a list of some of the medications that we use. I'm not going to go through these and read them off or tell you things specifically about them, but it is important to kind of know if somebody recognizes the names, these are antidepressant drugs, and sort of know these are used for antidepressants. There's only one little problem with this. None of these drugs themselves know they're antidepressants. Okay, they just do their thing. And because they do their thing, they have other effects beyond, quote, being an antidepressant. They may reduce anxiety. They may cause a side effect over here. They can do a lot of different things. So we label a drug antidepressant because of the way we use the medication, not necessarily because of what the drug is potentially capable of doing, either in a positive or in a negative way. But this is the list of the antidepressants that we typically use. Psychotherapy has been proven to be effective, and there are many different types of therapy that can be used. Cognitive behavioral therapy, interpersonal psychotherapy. Most of the studies that have been done, that have been controlled studies, in other words, the good studies, have not been of psychodynamic therapy. They've not even been of cognitive behavioral therapy. They've been of a type of educational therapy called interpersonal therapy. And this is not where you bring a group of people together and get them working well together. It's an approach to therapy that deals with interpersonal relations on an individual basis. These usually last about 16 sessions. And just to give you a description of this, in the initial phase, the symptoms are explored, and then you sort of begin to figure out sort of where are the problems. And then you might concentrate on one of different types of interpersonal problems. So that problem may be grief. It may be an interpersonal conflict, parent and child. It may be role transition, going from work to retirement. It may be interpersonal deficits. In other words, I just can't get along in a crowd. And so that becomes the focus of the therapy, and you work individually with the person on this. The reason I bring this particular one up is this is the one that's been studied the most in older persons with depression. Chip Reynolds, who has been one of the pioneers in looking at the treatment of late life depression, has found that this therapy, along with using medications in people who have major depression, the more severe depressions, it can be quite effective. And then there's another kind of therapy that we use that we always sort of get nervous about, and that's electroconvulsive therapy. It has a role in treating older persons, and probably half the people who receive electroconvulsive therapy are 60 years of age and older. So medications may be a little bit less effective. Electroconvulsive therapy can be quite effective in some individuals. There are problems with electroconvulsive therapy. The stigma probably is the major problem. In terms of safety, it's probably just about as safe as using the medications the way it's used today. But you have to be careful about it, because you can bring a person out of a depression, a severe depression, relatively frequently. using electroconvulsive therapy. However, that individual then is at very high risk of dipping back into a depression again. And so you have to be concerned about sort of how you manage the likelihood of relapse once a person is out of the depression itself. Okay. So I've always said that when you're treating depression in late life, you're treating not just the patient, but you're treating the family. So here are some of the things I think are important in treating the family. Interpreting changes in the older person's behavior, guidelines in managing certain dysfunctional behaviors, and preventing strategies for potentially dangerous behaviors, that is suicide. So for example, if you've got an older person who's depressed, you talk to the family, you say, get the knives out of the house, get the guns out of the house. You give the medications. Don't let them have charge of all of their medications. Just watch them, and perhaps don't let them drive alone for a period of time. All of these would be ways to kind of help the family, help the patient. But at the same time, you make clear the family recognizes that no one can totally prevent a suicide. So you do not want to put the burden of suicide on a family, saying, if you do this, this, and this, you can prevent it, and then if the unfortunate event occurs, then the family feels this blame. You do not want to do that, because suicide, from an absolute perspective, cannot be prevented. From a relative perspective, you can do things to decrease the risk. Dr. Reynolds also said that in a study, I'm not going to read through this, that you can increase the likelihood that persons do not fall back into a depression over at least a couple of years by that combination of antidepressant medications and this interpersonal psychotherapy. So here's some key points I want you to remember in terms of depression. Late life depression I'm going to read from over here. Late life depression may not be as frequent as at other stages of the life cycle, yet its frequency is high enough and very high specifically in the physically and the cognitively impaired. Older adults appear to be more vulnerable to biological causes of depression, such as depression secondary to vascular lesions in the brain. Older adults who are cognitively intact may experience a buffering of depression because of a lifetime of cumulative wisdom coupled with a different view of events given their age. So just to expand on that just for a moment, there are a lot of biological reasons older people should be getting depression more often than younger people, and yet the epidemiologic data suggests that older persons don't get depression as often. And so we think that probably psychological and social factors, for example, a lifetime of wisdom, actually may prevent or at least buffer the likelihood that older persons will develop a depression. The combination of psychotherapy and antidepressant medications, as I've said, is optimal. And ECT is indicated in rare but very specific conditions. Second condition I'm going to go to is generalized anxiety disorders. These are frequent. Older adults may not find terms such as anxiety ones that they typically use, but they'll talk about worry or they'll talk about concern. And you might ask the question such as, older adults often deal with stress. How do you feel in times of stress? And their answer might be a clue, or should be a clue, in terms of whether or not they may be suffering from generalized anxiety. During the evaluation, one should focus on levels of distress. Most of us will have periods of anxiety, but to what degree does this really stress us and really cause dysfunction? How much time do we find ourselves involved with our anxiety symptoms? Do we find ourselves avoiding situations because of anxiety? I don't want to go to church. I don't want to go to synagogue. I don't want to be with people. I'm afraid to go to the store. These are symptoms where you're getting into where this becomes disabling. And physical symptoms, such as, I just feel so tense and everything, beginning to have pains, etc. This is another thing one has to be concerned about. Now, here are the diagnostic criteria. I'm not going to go through these in great detail, but I do want to concentrate on the third category here, of what sort of things that one feels if one feels a more severe form of anxiety. To make the diagnosis, you need to have 3 or more of these. That's not so important for you to know as to sort of what are the things we include. All right, restlessness, feeling on edge. And it's an internal restlessness. The person may be able to sit, but they feel like there's something they can't sit still mentally. Let's put it that way. That's a little different than agitation, where they literally have to be getting up and moving around. Fatigue. Anxiety drains your energy. Difficulty concentrating, again, very similar to depression. Just can't keep their mind. Maybe like to sit and read a book, but they can't read that book because they can't concentrate. Irritability. People who generally are even-tempered, all of a sudden, are not even-tempered. They're snapping at a spouse. They're snapping at their children. Muscle tension. They just kind of feel tense like this. And problems with sleep. And here the sleep is problems are generally a little different. These people have trouble going to sleep. And because of that, they often will self-medicate. And because they self-medicate, that creates problems for them. They might use alcohol, which is a very bad thing to do in terms of trying to sleep, because the alcohol is a short-acting. It may put them to sleep, but they're up 3 hours later. Or they start using sleep medications, and they use more and more sleep medications because they're having trouble going to sleep. So this is a real issue that we have to deal with. Okay, how frequent are these? Generalized anxiety disorders are probably one of the most frequent problems we see in the elderly, but it's not talked about as much because it's generally not as severe as these more severe depressions or the problems that we see, the behavioral problems we see with Alzheimer's disease and other dementias. First onset may be as high as 50% in older persons. And anxiolytic drugs, these are drugs like Xanax, lorazepam, etc., also are very highly prescribed in older persons. So I mentioned that older persons, maybe 10% or more, are taking antidepressants. Probably 8% are taking some kind of anti-anxiety drug. So these are very frequent drugs that are being used, usually prescribed by primary care doctors. And so if you're working with older persons, don't be surprised if you see both an antidepressant and an anti-anxiety drug in their medicine cabinet in terms of drugs that they're taking. Unlike the antidepressants, which generally are not fun drugs to take, and so people will usually take them according to their prescription, anti-anxiety drugs tend to be fun. And therefore, people begin to take more of those drugs than they normally should be taking, and that can lead to some very significant problems. This is a lot of overlap of generalized anxiety with other conditions. Depression, anxiety and depression often travel together. And so again, the body doesn't know I've got depression or I've got anxiety. The body is feeling particular symptoms that actually may be coming from some of the very same causes, but the symptoms of depression and anxiety often coexist. Also is associated with cardiovascular disease, and so we have people who have cardiovascular disease. We've got to be very concerned about anxiety, and these individuals, especially those who have shortness of breath. Parkinson's disease is another condition that's been associated with increased anxiety, and stroke. Often following a stroke, people will have considerable anxiety. So when we're looking at comorbidities, we really have to consider all these different things that might be interacting with anxiety. So the anxiety is not usually a simple, straightforward diagnosis. It's often seen with dementing illnesses, and the social milieu of the older adult may be particularly precipitant of generalized anxiety. So you have to look at the environment in which the older person finds herself or himself. And so, for example, being in crowded areas or in noisy areas may induce or increase the likelihood of anxiety, or if somebody has anxiety, increases the severity of that anxiety. Concerns for safety. If you're living in a situation where you just feel like you can't step out of the house, or you're even afraid that somebody may break in the house, obviously that can lead to anxiety. concerns about your family. So whenever you as a caretaker, whenever you as a clinician are considering individuals with anxiety and they come in and they talk about being anxious, it's very important for you to ask about the situation. What are the things that make you anxious? And there may very well be clear reasons why they're experiencing anxiety. So what can we do? The medications, benzodiazepines, these are drugs like lorazepam and alprazolam. This is Xanax and Ativan, if you want the trade names of them. You've seen these drugs all the time. They're used, and as I said, they're used frequently. They can be used effectively with older persons, but you have to be very careful because of the potential addictive problems with them. So you really want to use them for short periods of time, if at all possible. Also, some of the antidepressant drugs, the group that we call selective serotonin reuptake inhibitors, these are drugs like Prozac, paroxetine, escitalopram, and citalopram, sertraline, all of these potentially might help with anxiety as well. So these are antidepressants, but they may be prescribed for anxiety. Again, the drugs don't know that they're just for depression. But on the other hand, antipsychotic drugs, these would be drugs like quetiapine, Zyprexa, etc., you really don't want to use in anxiety disorders unless the symptoms are just absolutely so severe, nothing else will treat the symptoms. And then there are non-traditional therapies, and so this has become much more popular. We see all sorts of things out there. For the most part, non-traditional therapies have not been proven. Some of them make some common sense, some of them don't. I'll just go through a few of these just for a moment. Stress reduction approaches can be very helpful if the anxiety is fairly mild and it actually is fairly short-lived. For people who have had chronic, moderately to severe anxiety over longer periods of time, these types of interventions just don't seem to help as much. And these may include things like Tai Chi, yoga, etc., relaxation techniques, etc. Medications that are out there, and there are a number out there, Kava Kava, for example, Valerium, others. No real evidence any of these are effective in treating generalized anxiety. Psychotherapy, again, the cognitive behavioral therapies, the educational therapies, there has been some evidence that they can be effective. They're not as effective in anxiety as they are in depression, but they may be effective. Again, it's because anxiety tends to stay there for very long periods of time, and trying to intervene with therapy can be some help, maybe helping the person adapt to the anxiety, but it doesn't necessarily make the anxiety go away. Relaxation training, again, milder cases, might be very effective. And people have talked about bibliotherapy. And this is basically just reading, maybe talking in a group, and just easing yourself. That actually can help some with the anxiety as well. So here's some key points from generalized anxiety. Again, I'm going to turn back over this way also. Generalized anxiety is more frequent than usually assumed. So you must ask the patient to elicit the symptoms. The evidence base for treatment is limited, more so than for depression. We just are not as good at treating this, but it's emerging. Clinicians must take care in the use of medications because the drugs that we often want to use are drugs that potentially can be addicting and people can develop a tolerance to. And you always want to be evaluating for comorbidities, things that may be causing the anxiety or things that may be complicated by the anxiety symptoms. So let's go to a third group, alcohol use disorders. And specifically, so look at my time here, I'm going to be talking about overuse of alcohol and also binge drinking. There's a sense out there that among some people that substance use disorders are rare in older persons. We don't have to worry about it. And there's some other individuals who would say the substance use disorders are really just going to be the big problem we're going to be facing with older adults in the future. And we can forget about Alzheimer's disease and we can forget about depression because it's going to be, the potheads who are aging into late life that we've got to be really concerned about. Neither of those are true. We've got to take a more nuanced view of how we deal with alcohol problems in later life. They're a problem, but they're not perhaps going to be the biggest problem that we will face. I'm going to skip over this, but this is just an example of some of the statements that have been made. And I want to talk specifically about alcohol. Alcohol use and abuse among middle-aged and older adults individuals is relatively low, but the frequency is increasing. And it's increasing for every generation that we see age in. So I was born in 1944. My generation has a relatively low use of alcohol. If you're born in 1954, your generation has a higher use. Born in 1964, higher use even. 1974, even higher use. And so what we're seeing individuals come into late life who are carrying a higher burden of substance in general, but specifically alcohol, than individuals in the past. And we have to keep that in mind as we go through. Most people 65 years of age and older do drink. We did some studies, and some others have done studies that suggest that this one here about the 37%, I think it's a little old. We actually, in our studies, found that about 55% of men and like 40% or 45% of women reported that they were actually drinking at the time that they were. People who actually carry a diagnosis of an alcohol use disorder is lower. It's probably around 1% in women, probably around 4% in men. Okay. Reasons for the increasing prevalence in the use of these disorders are the following, at least a couple. There's a lot of suggestion in the community that, and this comes from physicians, that a moderate use of alcohol is good for your health. And there's actually some pretty good evidence that that's the case. So if you maybe drink one glass of wine, red wine specifically, in the afternoon, that you actually have a longer life expectancy than if you drink no wine in the early afternoon. And these have been relatively controlled studies. And so people, I think, perhaps have sort of gotten the message that it's okay to drink. So people who've never drunk in the past may actually start drinking. And so that may be one of the reasons that we're seeing an increase. But I think that's probably not the main reason. I think it's this cohort effect that I described to you before. In other words, younger groups are bringing heavier levels of alcohol use into late life. Certain patterns of alcohol use may lead to unique problems in the elderly, and I want to specifically focus on binge drinking, which I think is especially an issue that we need to look at. We did a study where something like 13% of men and about 4% of women in the last month reported that they had been on a binge, and binge here is drinking 5 or more drinks at any given setting. That for older people is especially dangerous. And so we really need to be watching this issue of binge drinking as we move into late life. So how do you kind of look? I think I'm going to skip over this one and kind of move to this. We did some studies of alcohol use, and I think this classification is useful in terms of sort of how you assess whether a person is actually experiencing a problem with alcohol or not. So one group is just no use of alcohol at all in the last year. The second would be like on average 1 drink a day, or maybe 1 drink occasionally, but they would never drink more than 1 drink. So if they sit down to dinner, maybe they go to a friend, offer a glass of wine, they drink that glass of wine, they don't have the glass filled again, they just drink that 1 glass, that's it. That is a low-risk group. We don't tend to worry about them at all. There's an at-risk group, and this is defined by the American Geriatric Society as drinking 2 drinks a day or more on more days than not within the past 30 days. So 2 drinks at any given time on a fairly regular basis is what we think sort of the threshold at which we need to be concerned. And so that's not alcohol abuse by definition, but it's sort of a threshold where we need to begin to pay more attention. And the final one is binge drinking. As I mentioned before, we define that as being 5 or more drinks at any given setting. Typical situation might be the older person goes to a party in a retirement community. They don't know many people. They're nervous. They're anxious. They take a drink. They take another drink. They don't realize how many they've taken. And then they've taken 5 or 6 or 7 drinks. And then they're kind of wandering about. Now, the question is, now, what kind of drink? Isn't wine better than hard liquor and so forth? And beer is even better than wine. And so it doesn't really make any difference. I have one of the patients I remember very clearly in my mind that I treated for quite some time who did not think he had an alcohol problem, didn't drink at all until 6 o'clock at night. Between 6 and 11, he drank 10 beers on average. That's a problem. He was having trouble sleeping. I know why he was having trouble sleeping. He was having some trouble concentrating. I know why he was having some trouble concentrating. He had a problem with the alcohol. But he said, I'm only drinking beer. It's not so much the type of drink, but how much. And so this issue of 5 or more, 5 beers at one setting is a problem, okay? 5 drinks of scotch at one setting is probably a greater problem, but 5 beers at one setting is a problem. Okay, this is from another study, Bobo, in 2013, and I think this maybe kind of gives you a sense of sort of what we see as sort of the pattern of who's drinking. So, consistent, infrequent, and non-drinkers in this particular sample. This is from the Health and Retirement Survey, which is a good survey, national survey, showed that people between 50 and 65, 40% were non-drinkers or infrequent drinkers. 5%, a little bit over 5%, were actually increasing their alcohol intake gradually over time. It's a fairly low percentage, and typically older persons tend to decrease their alcohol intake. Decreasing drinkers made up about 7%, so that they were clearly increasing. Consistent at-risk drinkers, that's that group like 2 drinks or more, 15%. That's actually a relatively high percentage of this group, 50 to 64. And then consistent moderate drinkers at 30.7%. And this is a group I would really want to be watching. I really would want to be watching this 30.7%. Infrequent drinkers initially were less likely to follow an increasing trajectory if they were older. In other words, as you get older, there's a tendency to decrease your drinking. But that is offset by the fact that these newer cohorts coming in are carrying a heavier burden. So my cohort may go from 1 glass of wine a day to 1 every other day. But the 1964 cohort, when they reach the age of 65, may go from 6 beers a day to 4 beers a day. So we can see a decrease in each group, but the relevance of that decrease may not be the same for the 2 different groups. So we have to really consider this cohort effect, which I think is a very important one, and in fact, the thing that happens to be driving this whole thing. Okay, there are a lot of comorbidities with alcohol use. Depression is the main one we think about, but dementia is another one we have to be considering as well. Sleep disorders frequently go along with this. But in addition, whenever you have somebody who's drinking on a regular basis, you have to be asking about falls. Now, I think if you're working with older persons, you need to be asking about falls anyway. That should be one of the questions that you never let the person out of your office unless you ask them the question, have you fallen since I last saw you? And if they say yes, how many times have you fallen? And get some description of how that fall took place. That's very important. And it may be something just like I did a couple of weeks ago where I was jogging and I tripped over my shoelaces. And that's probably not so serious, though it did scrape me up quite a bit. But when somebody says, I was walking along and I just, and I came to a little bit uneven surface and I fell. I was in the house and there was a little something on the floor. And I tripped over that and I fell. You become more concerned about that because that may be related to the fact that they're not as aware because they're drinking. How do you treat this? There are a number of different treatments. Whenever you see a list this long, what you often think about is we don't have a clear treatment. So when you have a lot of different things, you sort of recognize that. But all of these potentially may help. Brief interventions, just the doctor saying you really need to cut down on your drinking, can be of benefit. So keep that in mind as we go through this. Psychotherapy, I think mixed views on whether that in the long run in terms of controlling drinking can help or not. 12-step programs such as Alcoholics Anonymous, that's the most effective way we can manage alcohol. The downside is that most AA programs really are not suited for older people. There are people to have, for example, if you go into an AA program at the age of 75 and your counselor is 25, that's probably not going to work. And so I think we need to consider the possibility of having 12-step programs. And I think there are some around already, but we need to think about this more, of tailoring 12-step programs more to the older person who has a problem with alcohol. And then there are a number of medications that have been used. These are more or less effective. The one that's been around the longest, disulfiram. One that's being used more frequently recently is naloxone, naltrexone. And then also acamprosate is something that is sort of just coming along. No real evidence that this is effective yet, but people are sort of looking at that. These drug therapies, which basically inhibit you from your desire for alcohol, that could be a wave of the future. I don't think we're quite there yet. And one of the reasons is that drinking tends to be a habit, and the drugs don't necessarily. And you've got to cooperate with taking the drug, or usually you have to have somebody in the process. So I really think if you want to concentrate on one of these therapies, I would look at the 12-step programs. Let's see. See, I'm having trouble advancing. Can we go to the next slide somehow? I don't know how we do this. Let's see if this. All right, good. Okay, whoops. I went maybe too far. Okay, some key points about alcohol. The potential adverse consequences of at-risk and binge drinking increases individuals' age, even though the frequency goes down. Falls, memory loss, liver disease, etc. The elderly are more susceptible to health problems, yet these can be often overlooked by clinicians. We just don't ask. In addition, usual screening instruments such as the cage doesn't pick up some of the problems that we see, such as binge drinking. And treatment episodes for substance use disorders in late life are increasing proportionally, most of which are secondary to alcohol misuse. And then given physiological changes associated with aging, adults 65 plus of age should consume no more than one standard drink a day if they're going to drink. Alcohol also acts synergistically with other medications, especially the benzodiazepines. So we have to be careful about what other medications the person is taking. And then the symptoms of alcohol misuse often are confounded with symptoms of medical illness. And so a person may be coming in and describing a host of illnesses, a host of problems, and we don't ask what the central question is, and, are you drinking, and if so, how much? And you need to kind of press the person. The person's a little fuzzy about that. You just need to really press on how much alcohol you actually are taking. Let's move on to the last one of our topics here, delirium, and I'm going to go through this relatively quickly. But this is an important one because it is so frequent in hospital settings and has a potentially such an adverse outcome if you kind of look at it over the long term. I'm going to actually pass this by. This is actually our DSM-5 criteria. I'm going to move instead to a very popular screening instrument called the CAM, the Confusion Assessment Method. And basically asks people in like an intensive care unit or on the floor to ask 4 questions and try to answer those. And then based on those answers, you can determine whether a person is experiencing delirium or not. Acute onset and fluctuation. Is there evidence of an acute change in mental status from the patient's baseline? And did this behavior fluctuate during the past day? That is, tends to come and go or increase or decrease in severity. So acute onset and up and down status is sort of one of the first things you want to look at when you're considering the possibility of delirium. Second, inattention. Does the patient have difficulty focusing attention? For example, being easily distractible or having difficulty keeping track of what was being said. In other words, you're having a conversation with the patient's looking out the mirror, looking out the window, looking in the mirror, staring around, saying, "Oh, what did you say?" That should be a clue that you're experiencing or you're looking at a possibility of delirium. Third, disorganized thinking. Is the patient's speech disorganized or incoherent such that rambling or irrelevant conversation, unclear or illogical flow of thoughts, or unpredictable switching from subject to subject? In other words, you're trying to carry on a conversation and they're just jumping all over the place in their conversation. That should be a clue of delirium. And 4, altered level of consciousness. Overall, how would you rate the patient's level of consciousness? Many people with delirium are perfectly alert. And so this is not the way to screen delirium out. But you also, in fact, they even may be hyper alert. They just seem to be aware of everything. Their eyes are wide open. But then they may be lethargic and drowsy, and that would be a clue of delirium. When you get below that, you kind of go into levels of consciousness that we don't generally classify as delirium, and that's stupor and coma. If you're working in a hospital setting, you need to be looking for delirium. It is a very frequent thing that happens, especially in the ICU, especially following surgery, but it happens to a significant number of people regardless. So this is something to be aware of. So what are the predisposing factors? Okay. And this is sort of, if you have an ability to kind of go upstream and hopefully decrease the likelihood of delirium occurring, these are some of the things you want to look at and see if there are ways you might intervene, such as older age. Older people are more likely to become delirious. Severe chronic illness. If there's a way to get an illness more stable, for example, diabetes or hypertension, that will help. Neurological disease or cognitive disorders, you may not be able to do anything at the time, but you need to be aware this is a risk factor. Dehydration, you can do something about that. Drugs, get people off the drugs that might be causing problems with their thinking. Functional dependence and immobility, and those a person can't get up and get around, they're more likely to be experiencing delirium. And then vision and hearing impairment, they're at greater risk as well. And then we go to the things that might cause the delirium on the spot, and drugs lead the list. And so people are on these drugs, and that is the thing that often will cause delirium. But there are many other things as well. Changes in the environment, moving from home to the hospital, to surgery, to post-surgery care, back to a room. All of those moves certainly increase the likelihood of delirium. Acute age of onset, for example, something of bowel obstruction. So you have an illness that just comes on suddenly. That can increase the likelihood of delirium. Pain increases the likelihood of delirium. Acute onset of neurological disorders, stroke, can certainly lead to delirium. Infections, hypoxia. This is a very long list. And I mentioned surgery here at the last, but people coming out of surgery, especially cardiovascular surgery, are a significantly high likelihood of developing delirium. So what can you do? Well, the things you can do that don't have anything to do with drugs that need to be kept in mind. First off, kind of look at the risk factors and see what you can do to try to modify those risk factors, or at least they keep you attentive to the likelihood of the person developing delirium or not. Use reoriented approaches if possible. Put a clock in the room, maybe a calendar with a big sign what date it is. Keep the light on in the room. Minimize physical restraints if at all possible. And verbally orient the patient. When you're drawing blood, you come in and say, I'm coming in to draw blood, but you don't just stop there. So I'm going to put this tourniquet on your arm. Now you're going to feel a prick. Now just hold still. I'm going to be just a minute. Now I'm taking the needle out. I'm taking the tourniquet off. We're going to put this bandage on your arm for a while. You hold this. Just keep talking to the individual and letting them know what you're doing will decrease the likelihood that they'll be confused about what procedure you're involved in. And their pharmacological treatments also. Haloperidol is sort of the drug of choice, but you want to use it in a low dose. And you want to use these drugs as little as possible because drugs are the leading cause of delirium, And when you add a drug in, you are increasing the likelihood that that problem may continue. Okay, some key points about delirium. Delirium is a common and preventable problem among older adults. Delirium is the most frequent complication of hospitalization, so that's very important to keep in mind. And this continues after the person leaves the hospital. So you may be in an aftercare program where you're looking in on the patient at home. Don't assume that once they're out of the hospital, the delirium is gone, because it can very well still be there once they reach home. Patients with delirium have worse prognosis than patients without. It's one of the reasons we want to treat this and treat it early, because their overall health can decrease based on the fact that they continue to have a delirium. Simple assessments are available. I just mentioned the CAM to you. Delirium causes are multiple. You want to try to eliminate whatever causes you have, but you've got to reconsider that very long list of potential causes. And finally, both pharmacological and non-pharmacological approaches are indicated, and you have to be very careful in terms of how you use them. So I want to finish up with just some 5 principles of working with psychiatric problems in later life. And these are the principles. When you've seen one older adult with a psychiatric problem, you've seen one older adult with a psychiatric problem. In other words, every patient is unique. We have to consider their diversity. Number 2, the foundation of the diagnostic workup is the interview. We learn by listening. If we listen, that's how we identify what the problem is. Not by some checklist, not by talking, not by an imaging study, by listening. A thorough medication history is essential, though it takes time. The electronic records hopefully are going to help us with this, but we need to know what drugs the older person is on for all of these potential problems that I've been going over. The key outcome we must trace is functional status. In other words, you want to get the person over the depression, you want to relieve the anxiety, you want to reduce the delirium, but ultimately you're interested in how they're functioning, how well they're able to do their activities of daily living, how well they manage their financial status, how well they can deal with their social interactions. Those are the things we need to focus on as we're looking at function over time. And then finally, geriatric psychiatry is family psychiatry. If at all possible, talk with a family member as well as talking with the older adult, because you get the complete picture in that way. And so thank you very much. I'm going to stop here, and I think we probably have time for a few questions, and I'd be very happy to answer some of those. Okay?
About 10 minutes for questions. Thank you, Dr.
Okay. Okay. So, yes. Yes, it can last. It can last months. I don't know if there's an absolute upper limit, but I mean it can last a long time. And so we have to. I mean, and people actually can recover even after a longer period of time. The longer it lasts, the more the prognosis, the more the outcome is in doubt. But yes, it can last a long time. There's been a number of studies that have suggested that. So yes, don't if it's not over with in 2 weeks, don't say that it's not delirium. It still can be delirium. But you still may have the cause there. It may be a drug, and the drug is still on board. Someone else?
Right here.
Okay, yes.
Can you please expound on the incidence of delirium in the PACU and the ICU, particularly following
I
medication?
think they run, I don't have those numbers directly in my mind, but I'm thinking they run 30, 40%. I mean, it's high. Peter, do you have the numbers right off here? I think about 30 to 40%. So it's very high. Now, many times delirium, you don't notice it because the patient is calm. They don't say much. And so you're not aware that they're delirious. And so we miss a lot of delirium in that way. Someone else.
We see the patient, outpatient. Patient have anxiety, family disease, or divorce of husband or children. Do you give the benzo, or the patient ask you to prescribe?
I think if a person is anxious over an event, life event, if at all possible, I would try to, not put them on a drug immediately, but try to maybe see them back in a couple of weeks and sort of say, you're anxious fairly certain because this event has occurred. Why don't you just see how you try to get through each day, do the best you can each day. If you're in a busy family practice, for example, you don't have time to do a lot. And then say, I'd like to see you back in a couple of weeks and see how you're doing. I think you're going to be better, and do that. Because I would not rush to use medications when you've got a clear event that's leading to depressive symptoms or anxiety symptoms. I just have to be very careful that way. I'm not hearing you. Huh? If they're very agitated and they really can't control things, you might very well want to go to a medication at that point. But you've got to use them very carefully. I think one of the things that happens in using the anti-anxiety drugs is that we may put the person on the drug, and the drug actually works quite well, and the person begins to like the drug, and so the agitation may actually have a lifespan without any medication at all of maybe a week or two, but 3 months later they're still on the drug, and they continue to take the drug. So you've got to be very careful in terms of the length of time, and you can't just stop the drug immediately once you put them on an anti-anxiety drug. You really have to kind of wean them off. You might, if, for example, they're taking Xanax 1 milligram a couple of times a day, which is not a small dose. You may say, well, let's go letting you take a half a milligram in the afternoon, taking 1 in the morning, half in the afternoon. Do that for a week. Then let's go to 1/2 in the morning, 1/2 in the afternoon. Let's do that for a week. Let's get you down to 1/2 just in the morning, and then let's go off of it. In other words, a very long period of sort of weaning them off. That's not physical. They don't need that long to be physically withdrawn. They psychologically have to get used to getting off the drug. So that sort of long weaning period can be very helpful. Yes?
Patients who have alcohol abuse.
Yes.
We have sat in some of the sessions for AA for the patients, and you see that the sessions are usually dominated by the younger patients. So your older patient is pretty much left out. So are there any available support for the older alcoholics that would probably cater to their needs?
I think there are. I don't know in this community, obviously, but I think in some places there are. For example, some retirement communities have AA programs. But I mean, it's a rare, sort of the rare person who actually can afford being in a retirement community. But there certainly are some. I think that's something that could be done more. I think that, for me, faith communities, one of the things that could be done is maybe to try to get an AA program started, perhaps specifically for older adults, and just use their space for that would be a very, very good thing for them to do. Yes. Okay.
Yes, sir. Could you please elaborate on the electroconvulsion therapy, such as how often is it used and how well?
What kind now?
The electroconversion therapy.
Electroconvulsive therapy. Okay. It is used. It's actually used rarely, but for example, in the major medical centers, probably like Vanderbilt or Duke or places like that, it'll tend to be used more because it's a referral center, and people who've not responded to therapies outside will be referred in for its use. But the majority of patients who are seen in these larger programs, I don't know exactly what the percentage is in terms of, but I would say probably of people who are diagnosed with major depression, I suspect less than 5% would be getting electroconvulsive therapy. So it's a fairly low percentage, and there's some fairly specific symptoms that you look for, including not responding to medications that would signal the possibility that the person might respond to electroconvulsive therapy. There's some other therapies out there now that are sort of less of concern, but they're not clear whether they're effective or not. One is what they call TMS, a transmagnetic stimulation, transcranial magnetic stimulation. And so you'll hear some about this. This actually could be done in a doctor's office. So I think that we just are not clear how effective they are yet. We've got to be, we need a little more time to see, but we're going to see more of these so-called brain stimulation therapies come along, and my concern will be, is there going to be maybe overbuilt in terms of their effectiveness. They are expensive therapies. Sometimes insurance will cover them, sometimes they won't. Electroconvulsive therapy almost is universally covered. Yes.
Yes, sir. I was going to ask your opinion on the cohort effect kind of running over into things like drug use or over medication. Do you see that as a potential problem?
Yes.
Oh, fair enough.
I mean, very simple. I mean, I think that, we're seeing abuse patterns that are not going down in like adolescents, college-age students, et cetera. So, and those are not things that they go down once the people get out of college and get a job, et cetera. But that cohort is going to carry that at a higher rate. I mean, most college campuses, and I know this is true at Duke, are very concerned about drug use, about alcohol use. I mean, those are big issues that we have to be concerned about. Probably, interestingly, alcohol use is the one that's of most concern. Even though we got all these other designer drugs out there, it's alcohol use that's the big one.
Dr. Blazer?
Someone else?
Yes, if you have someone that you know has GAD and some OCD and with a little perfectionism, or maybe even a lot of perfectionism mixed in there, but they've had that there for years. And then to maintain control in elderly, as they've grown old. I have a loved one who I just can't get her to go to a counselor or something. I mean, she stresses everybody out around her. When she had to go into a medical environment, she's almost 86. She stresses everyone else around, and she's a very warm and loving person. But if she's not in her home environment, she gets extremely anxious. And I just don't know how to get her help.
That is a very good point. I think one thing is that we should recognize is that a little anxiety, a little compulsion in some professions is not a bad thing, and people actually survive and do quite well during their working life with those. I must put myself into that category. But as you get into the retirement years and your time becomes less structured, the anxiety often will go up. And that may be what's happening in this particular situation. And in addition, if the person had significant anxiety perhaps earlier in life, and then they found that keeping active, keeping busy, keeping focused on something, it may be child rearing, it may be who knows what it might be, and then those responsibilities are lifted, and now all of a sudden they have free time, that can lead to significant kind of arousal again of the anxiety. The best answer to that, and it's not an easy one to implement, so I don't think you can say this just is going to work naturally. But the best answer from my perspective is that to get them again as involved as you possibly can, given their health and their capabilities. I want to stay on time, and I think I'm right at the end, so thank you very much.